afternoon. I hope you can see me. These things are always a little bit high for me. My name is Elke Schneider. I will be the moderator of this session today. I'd like to welcome you all to this session on carcinogens at work. And I'd like to start with a little bit of practical information. You have interpretation here because there will be one presentation in Spanish. So I hope you all got your earphones. For those who don't understand Spanish, with the channels on there. So please choose your channel. We will also ask you to connect to Slido and ask your questions via Slido. So after every presentation, we will take some questions from the audience as far as we can within the time plan that we have. So please connect again to Slido if you've disconnected in the meantime. And you can prepare your questions during the session. Please, could you turn your mobile phones to silent mode? And as I said, I will be chairing the meeting today, and also I will be reporting on the discussions in this session tomorrow morning first. So, I would like to, before we start, say a few words about this session. We have 3 presentations today. One of them is dedicated to public services. Then we have one that will concentrate on hazardous drugs in the hospital environment, and we have one on welding fumes. We've deliberately chosen these topics that are about substances that are not necessarily subject to chemicals legislation, but are subject to occupational safety and health legislation. So obviously there are more challenges to carrying out, for example, risk assessment at workplaces for these substances. But before we start with the first presentation, I would like to ask you a question via Slido. So could I have the first Slido question? Could you switch to Slido? Technician, there. And could I have the first Slido question? I have some technical problems of connection, but there are still people coming in, so. And we would like to know which organization you represent. So I'd like to ask you to answer to this first question. Are you from employers, workers' side? Are you from a government ministry, labor inspection, or service, for example? Okay. So has everybody answered? Has everybody answered to the question? Interesting. So most participants seem to be from government, from the employer side, a few from labor inspection and OSHA services. Okay. So could I have the next question, which is challenging your knowledge and also checking whether you've listened well to the introductory session of this event. How many workers in the EU are estimated to die from cancer due to exposure to workplace carcinogens every year? So if you've listened well, you should know the answer. Still answers coming in? Yes, it seems that everybody's listened well in the introductory session. So with that, I think we will switch again to the presentation, and we'll take the first presentation. Let me just present our speaker. So our first speaker is Marion Jaus from the Vienna Ombuds Office for Environmental Protection, who studied food and biotechnology at the University of Natural Resources and Applied Life Sciences. And since 1998, she is working for the municipality of Vienna at the Vienna Ombuds Office for Environmental Protection. She's the head of the Viennese working groups of Ökokauf Wien for disinfectants and for nanotechnologies, and member of the expert group developing the Viennese climate protection program. So Mrs. Jaus came by train, which is quite a courageous adventure to get to Bilbao in these climatic conditions. She's a member of several working groups at the federal level as the REACH platform and working groups for endocrine disruptors and for the development of the Austrian Nanotechnology Action Plan, and is going to present today on substitution of hazardous disinfectants in public services of the city of Vienna, more particularly on the VDES database. You have the floor.
Thank you very much, and thank you for the invitation to this interesting conference. Yes, welcome from my side. I think you should just open it. Okay.
That one, right?
Yes. Okay, fine. Thank you very much.
You're welcome.
Okay. Yes, I want to introduce to you the VDES database, and we just developed this database in the city of Vienna together with national and international experts, and just to assess disinfectants regarding occupational health and also the environment. And we developed this database in our program for green public procurement in the city of Vienna. It's called Ökokauf Wien or EcoBuy Vienna. And that's why I want to just introduce this program just very short to you, and also why we just focused also on disinfectants, because this is very unusual. I don't know any other GPP program that had a own working group to assess disinfectants. So I think, yeah. And afterwards, I will just show you a little bit of the structure of our database, and of course, how we work with it in Vienna and also in Austria, and what lessons we learned. Our GPP program was implemented about 20 years ago, and we have in Vienna a budget of about 5 billion euros per year to purchase goods and services. And I think this is quite a big power also to influence the markets. And that's what we try. We try in Vienna just to support ecological products and also companies. And of course, we also want to be a role model for other cities and communities with the work we just do. And we just implemented about 26 different working groups for all the goods and services that we purchase. And more than 200 experts are working there just to develop eco-criteria lists for our tendering, and also position papers and also tools as the VDES database for disinfectants. And I tell you this because a lot of working groups also create some criteria for occupational health, not only ecological criteria. So here you have the link to our website, and you can just look up the results. I think they are, for instance, also interesting for the working group for in interior decoration, the carpets, the colors inside of buildings, and so this is also interesting. And something special about our program is that all the criteria that we developed are binding by an executive decree for all the departments of the city of Vienna. And that of course helps us. Of course, we have, I think, several hundred people in the city that work in the field of public procurement, and of course it's still very necessary just to act as someone who does a service for these purchasers and to stay in contact. Yeah? Otherwise, I think it wouldn't work. But it's also good that we have this decree telling the people our criteria are binding and we are helping you just to implement them. So why did we just implemented a working group for disinfectants? It was because we saw that especially in disinfectants, they contain hazardous substances, for instance, CMR, with CMR properties, with allergenic potential, and we thought we should, and also some very ecotoxic substances, and so we thought it would be interesting just to find out if a substitution is possible. But the hygiene experts in the city of Vienna in the first years, I can say, were not really convinced that this is a good idea. They were a little bit afraid that we just then recommend disinfectants who are good for the environment, but they said these disinfectants are necessary to protect people's health and to protect lives against dangerous infections, and please don't come with ecological criteria. So in the first step it was necessary just to prove that this makes sense and that the environment is how you say, is also harmed by these substances. And the Federal Agency for Environmental Protection, they just made some measurements then in Austrian rivers to find out if disinfectants are a problem, and they didn't thought that they would find anything, because they said disinfectants are only used by hospitals and the concentrations will be low. But they were quite surprised. They found quite high concentrations of, for instance, quaternary ammonium compounds, especially in the sediment. And they said, yes, a harm for the aquatic organisms cannot be excluded. And of course, we also collected some studies about occupational health problems. And for instance, a French study showed that 20% of the patients that come to a doctor with skin problems showed that they had exposure to disinfectants or to detergents in the workplace. So also in this case it might be a problem. And here are some ways how disinfectants can do harm to the human health. A lot of them are corrosive, and they degrease the skin. Some of them are sensitizing, and there are also some others with CMR effects. And so they can cause toxic and allergic contact eczemas to skin, but they can also harm the respiratory tract, causing acute and chronic bronchitis or allergic asthma. For instance, glutaraldehyde is such a substance where it is investigated that it can just lead to allergic asthma, and they also can lead to eye conjunctivitis. So, and that is the composition of our working group. I am the head of the working group since I think 20 years, so I always say it's I have 2 children, and the database is something like my 3rd baby, and now it's grown up. And we work together with manufacturers of disinfectants and also of active substances. We also went to Switzerland and got there some confidential toxicological data. As at the beginning, when we started, a lot of toxicological data were not published and not available. And yes, we work together with hygiene experts, with the Consumer Association, with ecotoxicologists, and we are also funded by the Austrian Workers' Compensation Board. And of course, we work together with the hygiene teams of the hospitals, and we are funded by the Federal Ministry for Environment, and we also work together with the Ministry for Social Affairs. And we have also some international cooperation partners, and you can look them up at the website. So we started our work with 2 commitments, we can say. The first commitment was, yes, the use of disinfectants in hygiene risk areas is indispensable. And of course, it is the first and the most important issue that these disinfectants have a broad spectrum of activity and a good efficacy. That's, of course, the first thing. And the second commitment was that we said, yes, but several disinfectants show also relevant impacts on the health and on the environment. And so we just look, is it possible to substitute some of these disinfectants? We didn't know at the beginning. And so in the first step, we just collected all the safety data sheets of the more than 100 products that we used in the city of Vienna. And of course, we also collected safety data sheets of other products that we don't purchase and might be good candidates for substitution. And then we saw, oh, that's really a big work just to compare them. And first thing that we learned was that a lot of these active substances in disinfectants, there were no harmonized hazard classification. So every company just in the safety data sheets had different hazard standards. Yeah? For some active substances that were really important for us, one company said 2 hazard statements are relevant, and another company said 7 hazard statements are relevant for this substance. So, okay, so what is right now? The second thing that we learned is that a lot of disinfectants are sold as concentrates. And they are, during the application, they are diluted from 20% to 0.02%. And of course, we know since Hippocrates that the concentration makes the poison. And we thought it's not realistic and it's also not fair just to compare the concentrates with each other. So we thought it would be better to compare the working solutions. And and next thing was that we saw a lack of data, and so we thought to make a good assessment and comparison of products, we will need a database. Otherwise, we cannot do a good work. And here is the database that we developed. And in a first step, we just did a research for all the human and ecotoxicological data that were available for more than 200 ingredients of disinfectants, and such as antimicrobial substances, surfactants, solvents. And of course, we always included the source references so that the database is really transparent for everybody. And in a second step, we just implemented or integrated more than 300 different disinfectants from the market supply, regarding the composition, regarding the spectrum of activity, independently certified, regarding applications, material compatibility, and of course, for this we used manufacturer data. And in a third step, we developed, together with international experts, an evaluation scheme to compare the human and ecotoxicological properties of the disinfectants on the Austrian market. And of course, this database also needs some sort of training that others can use it, and that's why we just made some training videos that you can find on the website, so everybody who is interested in using it can just do a training of about 25 minutes and then hopefully can use it in a good way. So it's not enough time to tell you everything about the assessment procedure, but we have also a video if you are interested in this on our website. And here is just a short introduction. In the first step, we just categorized all the adverse effects of disinfectants for human health and environment that seems for us relevant. And then in the second step, we just assessed all the ingredients with harmful properties or hazardous classifications in these categories. And then in the third step, we just developed a calculation model that allows us to assess the products on the basis of the substance assessment, taking into account every substance with hazard classification and considering always the concentration in the working solution of every of these substances. And here you can see the adverse effects that we assess. We thought acute toxicity is relevant, especially to the respiratory tract, because a lot of disinfectants ingredients are very volatile, so people could breathe them in. And then we just looked at the irritation and corrosivity, the allergenic potential, the CMR properties, and also specific target organ toxicity, and also the behavior in the environment in the surface waters for aquatic life. And here is the core of our assessment scheme, and the basis is the hazard classification of all the substances, and we just collected all the hazard statements which are relevant for the different categories, and then with a team of international experts we just ranked these hazard statements from low hazard potential to very high hazard potential. And we also transformed the assessment numbers that we assigned into a color code, so that it's more easy to see the red fields that say, here you have a hazard potential. And we also took into account data gaps in the database. So every substance where we could find no data, we just marked them with a question mark, so that you can also see the data gaps. I think this is quite a good idea. It came from one of the companies. And here you can see the toxicological profile, for instance, for glutaraldehyde. And you can say every substance in the WIDIS database gets some sort of report with 6 marks, if you want. And you see on the first view, okay, for instance, glutaraldehyde, it shows an acute toxicity and is also corrosive. It has a high sensitizing potential or allergenic potential. It has no GMR effects, although it is quite well investigated, and it has a moderate behavior in the surface waters. And then in the database, you can just look up all the different assessments of substances on one page. Here you have, for instance, all the aldehydes, yeah? But there's also a website page where you can look up all the ingredients at one page, and I think this is really a good information for, I just show it to you, it's really a good information on the global scale, yeah? So here you have, and we made also 3 categories in our new database that will be published in, I think, 1 month. And here you can see for all the ingredients the assessment, and you can also go to every substance. Every substance has a page with a profile where you can just see why we assessed it exactly like this, in this way. And so we just tried to be transparent. So, and now this just shows you how we assess the products in a comparative way. And so you see every product also gets some sort of report with 6 or 7 marks. If a product contains alcohol, we also just assess the flammability. And yeah, you can see with one view, okay, product C has CMR effects, for instance, or product A is sensitizing. And it's also possible to rank in every category. And what we didn't do is we didn't make or we didn't assess the product with only one summarizing assessment, because we thought that this is not useful, and all the users of the database must now think by themselves what properties are the most important. For instance, if you have a disinfectant in the field of instrument disinfection in a washing machine, then the exposure of people is very low. Yeah? But after the washing process, the disinfectant goes to 100% into the sewage water. So in this case, I think ecological criteria are more important. But on the other hand, if you think you are in a hospital, in a neonatology with little babies, then of course it's the most important thing that the disinfectants have no CMR effects, that they are not sensitizing, that they are not toxic for respiratory tract. So then, of course, it's much more important to look at the properties in the field of health protection or occupational health also. Yeah, and what we not do in the database, we do no life cycle assessment. We don't look at the production of the products or the substances, and we only assess ingredients that show some hazard statements. At the moment, we don't assess the endocrine disruptors, and yeah, and we have still some data gaps, but not as much as in the beginning. And we don't look at bacterial resistance of biocides. Yes, but I think it's still a very useful information that we can give. And here you have just an overview how many of the products in our database show really serious health hazards. And there you can see in the different fields of application, there are about 10 to 60% of the disinfectants show serious health hazards, as for instance suspected CMR properties or proven CMR properties, or chronic toxicity, or respiratory sensitization. And this shows, yeah, there are products that should be substituted, and there's also the possibility to substitute them because half of the products don't have these properties. And here it's just too short to explain it in detail, but here's just an overview. These are the ingredients we found in disinfectants that we think that should be substituted whenever possible because of CMR effects, because of allergenic potential, for instance. And here we have another slide showing you those active substances with lower hazard potential, for instance, alcohols, then organic acids or oxygen releasers. We think you should use as often as possible. Yeah, this slide is only just to say a big thank you to the European Commission and also to the European Chemical Agency, ECHA, because they really did a great work with the REACH regulation, with the Biocidal Product Directive, and we saw that data gaps that we had when we started our work just vanished away. I think we had in the beginning hundreds of question marks, especially with CMR effects, and now I think we have only a third of these question marks when in comparison to when we started, and it's, I think, really a success. And yeah, and what do we do now in our consultants' activities? When the database was published, we just went in every hospital in the city of Vienna, inviting all the hygiene teams, the teams for environmental protection, also the responsible persons for occupational health. And we just told them, please send us the disinfectants that you use at the moment. And then we just made a toxicological profile of them. And then we sit together and try to find, for those who had hazardous properties, some better solutions. And we also consult, for instance, the schools and the kindergartens that use disinfectants, or also the official swimming pools. And in a first step, we saw that the hospitals that used aldehydes in quite a big concentration and also recommended the use of aldehydes in their guidance line just switched and said after looking into the database, no, we don't want to use aldehydes anymore. And they just published a new guideline saying, please don't use aldehydes, especially for surface disinfection. And yeah, also our official swimming pools, they just had one ingredient with CMR properties, and we were not able to substitute it. Then in the first step, we could reduce the concentration by 50%. And in the second step, the manufacturer just changed the formulation because we just had a lot of telephone calls, what we can do. And so I think this is also a success. Or the Viennese schools, they just used antimicrobial soaps with triclosan. And we told them, don't use it anymore because it's an endocrine disruptor, and they stopped it within weeks, yeah? And just used normal soaps and general soaps. Ah, yeah, thank you. That's okay. And so I think, yeah, that's some examples. Yeah, here's an example for benchmarking that we did. and we always showed the department a comparison from the disinfectants they use in comparison to the most toxic disinfectant on the market and in comparison to the best, less toxic product on the market in our database, and showed them if you take the best one, you can, for instance, reduce the consumption of a substance with CMR effects by 50 kilograms per year, for instance, or by 1 ton per year. And I think this a sort of benchmarking just really raised awareness, especially if you have to do with in schools, with children or in kindergartens. So yeah, that is possible with our WIDES database. And yeah, we could see in our monitoring that in comparison to the most toxic products on the market, we could avoid 18 tons of harmful substances within 1 year in these different departments. And the potential for substitution was only 172 kilograms per year. But we could still just improve something. And in the last years, the Vienna Hospital Association just developed a list for recommended disinfectants, also using the WIDES database. And now if you compare the consumption of toxic substances at the beginning of our project, and now compare it with the recommendation list that is used by 90% of the hygiene teams or of the hospitals, then we saw that we could reduce toxic substances and sensitizing and substances with CMR properties almost to zero. And at the first year, they just had in the recommendation list own section for disinfectants with low allergenic potential, and now we have none disinfectants with fragrances that are allergenic, for instance, or any other substance with allergenic potential. So I think that's quite fine. Yeah, I think, yeah, this is not so necessary, but the use of the WIDES database is now recommended also by some ministries. It's recommended by the WHO and the ILO, by the European Commission as a best practice example, and now also by the OSHA. And yeah, that's also maybe interesting. The Ministry for Social Affairs, they just published a decree saying which disinfectants, hand disinfectants, are allowed for pregnant employees to use. And they have quite good restrictions. For instance, no fragrances with allergenic potential are allowed. And we saw, and the WIDES database is the instrument to find out which products are allowed to use by pregnant employees. And we saw that the market switched completely, the formulation changed. For instance, when we started, 10% of the hand disinfectants were perfume-free, and now they are about 70% of the products are perfume-free. So I think this is also a good example. Yes, and at a last slide, I'm not Martin Luther King, but I have a dream as him. And my dream is that the WIDES database could be a role model for the European Commission and for the European Chemical Agency, just to develop similar tools that are so that we are able to compare different products and their hazard potential as we do it in the WIDES database. For instance, the ECHA developed the register for biocidal products, and I think it would be nice if this register would be developed in something similar to this WIDES database, maybe with other criteria. But this would be a perfect tool for substitution on a European level, because I think we have 50,000 biocidal products on the market, and we just assess 300. So, and all the data that you need are in the R4BP already. Yeah, you can find them there already. So, and there was, we had a good contact to European Commission, to Christoph Kusendila, who was responsible for the sustainable use of biocides. And he just supported our idea, but he now changed the department, and yeah, we still hope that this idea does not die. And yeah, so if anyone is here from the European Commission or from the ECHA, it would be very nice if we just could meet and talk about this project. And yeah, I think that WIDES database is a role model maybe for the substitution of hazardous chemicals, and itself it can be used also on a global level, because the ingredients of disinfectants are the same on every continent. And the WIDES database is already used in all continents. We have only few users from Australia or from Africa, but we have users from every continent. And yeah, please also, I hope that the OSHA just helps to spread the information that this tool is available for everyone. Thank you.
Thank you. I have an immediate question to you, and that is, how did the producers of disinfectants react to your initiative?
They just worked together with us for several years. At the first time, they were quite nervous if we just would forbid some products for the city of Vienna, but that we didn't do. And we just gave the information to the purchasers and the users. And after, it was like this, that the people in the companies who just developed new products were very interested in our database, and they just gave us really good remarks and helped us to improve the database and the assessment scheme. But the managers for the sold managers, Verkaufsmanager, they were not amused with the database. And when we just tried to publish it, they just said that they will bring us to court if we just do that. They don't want it. And, but we just proved the database with, I think, 7 different laws, and then we just published it. And now the companies, they are really very good. They cooperate with us because they know it's in Austria important to be with the products in the database, just to have a chance to sell it. And now I think the cooperation is quite good. And we invite, of course, every company just to integrate their products, and it's cost-free at the moment. Yeah, thank you.
I think we need to move on, but I have a question for the audience, and that is whether you know of similar initiatives in your country that refer, for example, to procurement strategies or are particularly relevant to the service sector. And we'll keep the questions, because we went a little bit over time, we'll keep questions for the last part, if we have time for the last part of the... But could we switch to the Slido question, so that we know whether some of you have had similar experiences and would like to exchange experiences, if not in this session, then after the session in the evening. So can I invite you to answer the question? Let's see. So we have about 40%, so certainly there's room for a dialogue there between the different initiators. So I'd like to invite you to speak to our speaker and have an exchange of experiences. We'll keep the questions for the last part of the session. We went a little bit over time, and I'm wary of time. So I'm sorry, but we need to move on to the next presentation. So could I have the next presentation, please? And that is by Nuria Jiménez Simón from the Instituto Nacional de Seguridad y Salud en el Trabajo, the National Institute for Safety and Health at Work. Nuria Jiménez has been working as an occupational hygienist in this institute since 2010 and is working in the Center of Working Conditions in Barcelona. She has been responsible for the management of several projects, technical reports and guidelines, generally on OSHA issues. She's a pharmacist as a background. She started in the private sector, in the petrochemical industry. When she joined the institute, she's been involved in different sectors such as cosmetic manufacturing, pharmaceutical industry, gas and oil, and currently raising awareness on the use and handling of hazardous drugs in the healthcare sector. And she's going to be reporting on one of these tools that the Institute has developed and is going to be presenting on handling hazardous drugs in the healthcare environment and on the tools and guidance developed by the Institute. You have the floor.
Thank you very much, Elke.
Could I ask you to use your headphones if you are not fluent in Spanish? Because the presentation will be in Spanish, sorry.
Thank you very much, Elke. Gracias a la organización.
I would like to thank the organizers and the OSH, the agency in Bilbao, for inviting the Spanish Institute, the National Institute of Health and Safety in Spain, for allowing us to be here and tell you about our database on hazardous drugs, organized and managed by our institutes. We have representatives from our institute here with us as well. I want to thank them as well. So let's start with the presentation as such. The first group of drugs that was considered as hazardous for workers who had to handle them were antineoplastic drugs or cytostatic drugs or cytotoxic drugs, different labels and words for drugs to treat cancer. Back in the 1980s, we learned how these drugs had side effects for patients who took them, and also in the US, scientific evidence proved how malignancies that were treated with these drugs, those patients had side effects, cytotoxic effects. Then the second piece of information was about nurses who either administered or were in charge of the preparation of these drugs. Well, in urine tests, they found they had mutagenic substances in their urine tests. They had higher levels of those substances. Back in the 1980s, so quite a while ago, it was found that pharmacists and assistants who prepared these drugs or handled cytostatic drugs had chromosomal aberrations in urine tests. There was also an association between exposure to anti-neoplastic drugs and adverse reproductive effects in pharmacists or nurses that either handled or administered cytotoxic drugs. For instance, miscarriages or fertility difficulties and so on. And last but not least, since the 1990s, evidence was found that in hospitals and surgeries, environmental contamination of areas where cytostatic drugs are prepared and administered, that contamination level was concerning in healthcare facilities. So, as a result of all that evidence, changes were proposed. For instance, the need for changes in the initial preparation formulae, having new guidelines for preparation with a international consensus on best practice guidelines for cytostatic drug preparations. A decision was made for pharmacy services to be centralized and to deal with the preparation of these drugs so that hazard control was easier. And then in more recent years, different actions have been studied. For instance, ventilation systems, because fine, drugs should be prepared in special booths, but apart from that, certain pressure gradients and ventilation systems should be used in those booths with also the use of closed system drug transfer devices, so that cytotoxic drugs can be guaranteed to be free of any contamination, but also there's no contamination from the drug into the environment that would finally expose workers to that risk, that hazard. The Spanish Institute decided that a technical report should be drafted before the database project started, and that awareness raising was needed in the healthcare sector about exposure to dangerous medicines. Cytotoxic and cytostatic drugs have been mentioned so far during my presentation, but in fact our work has also included other drugs other than drugs used for cancer treatment in this group of hazardous drugs. So the Institute started with a draft list of hazardous drugs so that hazard could be identified. This initial list of drugs didn't intend to assess the risk level as such or level of hazard because hazard and risk assessment should be carried out at each facility. We also thought at the Institute that the technical report would help, but very, very important for the project to be successful would be for the database to have a mobile phone version that was intuitive, that was easy to access and use, And all of that with information that would be comprehensive thanks to us working with different stakeholders, whether it was patients associations and trade unions, gathering information from all of them. The technical report or technical document and the database really would only be successful if we managed to change attitudes in medical facilities, because best practice guidelines can only be successful if users propose them and design them.
Now, the Institute has been working since the 80s in this area, and I come from Barcelona, and in fact there, we've been working since the 1980s. Firstly, and at the end of the presentation, we have left you a series of bibliographic references for scientific papers that have been published by the Institute over this time. First of all, we focused at the beginning on mutagenicity and chromosomal aberrations and cytotoxic drugs. Then, during the 1990s, there were some technical documents that were published about exposure assessment, again focusing on cytotoxic or cytostatic drugs. And then in the year 2000, a very interesting study was carried out, which was to analyze the surfaces of the different working places in the hospitals around Barcelona. So the working surfaces in the hospitals and also the outside of the different vials of the cytotoxic drugs that came from the suppliers. And 6-cyclophosphamine was particularly focused on. So we focused again here on cytotoxic drugs, and then from 2016 onwards, that was really when we have broadened our horizons with this guideline and the database. We've included other drugs as well, not just cancer drugs, but other drugs that may be hazardous in general. Now, in the technical document and in the database, what do we consider to be hazardous drugs? So what are they exactly? Well, the definition that we give comes from the American Organization for Occupational Health and Safety. And the definition is that hazardous drugs are medicines with adverse health effects: carcinogenicity, mutagenicity, reproduction and developmental toxicity, and genotoxicity. And this includes cytotoxic drugs, but it's not exclusive to cytotoxic drugs. Now, as we've been hearing earlier about how many cancer cases there are today, now cytotoxic or cytostatic drugs are being used for anti-cancer treatments, but they're also being used to treat other types of diseases. There's an increase of the number of hospital workers exposed to these types of drugs. There's also an increase in the variability of the different types of hospital workers who are exposed to them, because they're being used for autoimmune problems, different liver problems, etc. So there's an increase in the number and the variety of workers who are exposed. So who might be exposed at work? Well, so far we've focused on the background, really, to the initiative, and we've been mainly focusing on nurses and pharmacists, but who else might be exposed? Well, there are two types of exposure: direct exposure. And direct exposure is basically due to the direct manipulation of these drugs. And here we could be talking about pharmacy technicians, pharmacy workers, nurses who will be administering them, physicians and physicians' assistants, healthcare auxiliary nurses, those who work in veterinary surgeries, who will either have to apply or prepare these types of drugs. They would be they would have direct exposure. But there's another type of exposure which often we tend to overlook, and these are the people who are exposed indirectly to these substances. Now, why do we say indirect? Well, because they might have contact with working surfaces which have been contaminated with this type of drug, or different contact with waste or with other substances that have come into contact. And we're not just talking here about hospital workers. For example, in retirement homes, people might be exposed to them, and community centres, because treatments are increasingly being given in community centres that aren't hospitals. And in fact, sometimes they're given to family members so that they can, in fact, apply or administer the drugs. So there is a huge variety of different people who might be exposed indirectly. Now, the turning point for all of this was when the European Parliament commissioned a report from a group of experts. They were concerned about psychotoxic drugs, but also about other types of drugs. And all this happened in 2015. And they commissioned a report which is based on the premise that the number of cancer cases are increasing, that we have to protect our health professionals who are exposed to these types of cytotoxic drugs and other types of drugs. And the aim was to come up with a series of recommendations which might be used to inform best practices to try to protect these types of workers. And they can be adopted by the European Union or adopted individually by each member state. Now, the report includes 11 policy recommendations. For example, they talk about control of exposure, control measures that need to be put in place. For example, they're saying that drugs being prepared in these safe booths is not just enough. It is good in its way, but it's not enough just to have chemists working in these sealed booths. It's not enough. They talk about the closed transfer systems for drugs, which was something that which NIO, the American Health and Safety Agency, came up with. The idea is to regulate how we're going to ensure in the European Union a prevention of exposure of healthcare workers to chemical risks. So a series of recommendations are given, practical recommendations in this document for control of exposure, which is what we're trying to work towards. Another important point is the report published by the IARC, the IARC, and in fact they studied 140 cytostatic agents, and of these 58 were in fact found to be carcinogenic, or even though it wasn't enough evidence for some of them to be actually classified as carcinogenic, even though some of the drugs. But this is, of course, according to the IARC report. Now, here we can see the American organization, NIOSH. And in the year 2004, in the United States, an alert was issued. This was the first alert that was issued in the States for health establishments, asking them to assess risks properly. And in this first alert in 2004, a simple list, an initial simple list was published of these hazardous drugs. Because often what happens is that some people know what the drug is for, what it's used for, but they are unaware of how dangerous it is or how hazardous it is for those who are handling it. So this simple list of hazardous drugs was published in 2004. And from that moment onwards, what NIOSH decided was that once every 2 years, it would update this list of hazardous drugs. In some years, they have eliminated some drugs or they've added other drugs. There's a working procedure that they have established, which means that they base their findings on toxicology findings, toxicology studies carried out by the American Environmental Agency, the American Health Agency, etc. So it's a very reliable source of information, and deciding which hazardous drugs are going to in fact be included on the list has the support of the American Society, the American Drug Agency, which supports the whole process. And it also has different reports commissioned from the manufacturers as well. The first list was published in 2004, and the latest one was in 2016. In 2018, a new list should have been published, but unfortunately it wasn't. The first organization to actually use the term hazardous drug, because it seems weird, right? Because, you know, medicine is supposed to cure you, so a hazardous medicine or hazardous drug is quite shocking, really. But the institute that first did it, that first coined that term, was the ASHP, the American Society of Hospital Pharmacists. This was in 1990. They coined the term hazardous drugs, and they included the series of recommendations. And as I said, the latest list was published in 2016. Now, what is considered to be a hazardous drug in the NIOSH list? Well, you can see them up there on the screen. Those that have carcinogenicity, teratogenicity, or other developmental toxicity, reproductive toxicity for both men and women. So anyone who wants to conceive, be they man or woman, if the drug is going to have an adverse effect on their ability to conceive, then that is classed a reproductive toxicity. Organ chronic toxicity at low doses, genotoxicity, and those that have a structure and a toxicity profile that are more or less the same as existing drugs, but they are in fact classed as hazardous. Now, the drafting of the list is done in collaboration with prestigious experts, and in the first group, we had other drugs that weren't cytotoxic drugs or cytostatic drugs. They weren't cancer drugs. And we're not just talking about the pharmaceutical formulations. I'm not talking about whether it's I'm talking about whether it's a pill or whether it's supposed to be injected, whether it's a perfusion, whether it's a capsule, etc. So we included different tablets and different formulations and different drugs that weren't cytostatic drugs. So from the simple list was the original one, but 3 more groups have been added to it since then. Now we have the anti-neoplastic drugs, which was the first one. Now these drugs they had to be very, very careful when people were handling these drugs. The second group were the non-anti-neoplastic drugs that could meet one or more of the NIOSH criteria for being a hazardous drug. And group number 3 were the drugs with a reproductive risk. Now, this doesn't mean that in Group 1 or Group 2 we don't have any drugs at all that might pose a reproductive risk, because there might be. But these are the 3 groups that were established. And they did that to make it more operational, easier to actually apply and to do something with that information. So we have drugs that weren't cytostatic drugs, which were included on this list. Now, why is it important to know the dangers of the hazardous drugs? Well, because if you don't know how dangerous a drug is, or any chemical is, then it's very, very difficult to actually evaluate the risk. Without knowledge, there can be no risk assessment and there can be no preventive measures taken. So how do they identify the hazard in the health establishments? Well, in fact, the CLP regulation doesn't apply to these drugs. These drugs don't have safety data sheets for these medicinal products. They don't have labels with these little pictograms telling you why they're hazardous, etc. There's no hazard statements. You won't find what you can see up there on the screen, which is what we can see in the chemical industry, for example. We don't have that. So what do they have? Well, they come under the Medicinal Products Directive. And what does that say? Well, it says that the information about pertinent information needs to be provided to the user, but it needs to be done through the data sheet and the package leaflet or the prospectus. And that's generally read by the patient. And the data sheet, they talk about the therapeutic indications, the dosage, etc., second side effects, etc. How am I doing for time, Elke? 5 minutes. Okie dokie. Thank you. So from 2006 onwards, the Institute published this guide to hazardous drugs, and it included 173 medicines or drugs for humans in collaboration with the Spanish Association of Hospital Pharmacies, which have been collaborating with us right from the very beginning. Now, the NIOSH list was taken into account, the list that was published in 2016. Now, this includes the name of the medicinal product, which are marketed in Spain, which appear on the NIOSH list. And also, it includes the galenical form. It was included for each medicine, and the pharmaceutical form. So, for example, if I'm prescribing or administering a pill, it's not the same as if I'm going to be handling a perfusion or a pre-injection solution. We also included the NIOSH guides, the United States Pharmacopoeia 800 guide, the International Society of Oncology Pharmacy Practitioners guide, for example. Lots of different guides were taken into account. You have them all up there on the screen. And we also worked with different working groups of the Spanish Society of Hospital Pharmacists. And what happened? Well, the document was on paper, and as soon as it was published, it was out of date, which is often what happens. We follow the NIOSH criteria, and it just goes out of date. So what did the Institute decide? Well, instead of just a paper publication, let's set up a database, an online database, an online instrument, which will include all the different active substances classified by NIOSH as dangerous and the different medicines that contain them. And we're going to include preventive recommendations, general preventive recommendations. So this is what's included in the database. We say these are the general preventive recommendations. This will, is not a risk assessment. It just helps you to begin. It's a starting point for risk assessment. It's an initial hazard identification. If you have a look in InfoMep, you'll see this. I'll see if I got time to show you at the end. Now, the advantage is that all marketed drugs are included there. So any user can, from their mobile phone, look up a drug to see whether it's been classified by NIOSH as a hazardous drug and what recommendations are attached to it. You can search by drug, by active principle, presentation, etc. And we have collaborated actively with the Spanish Society for Hospital Pharmacists, or of hospital pharmacists in this. And all the drugs marketed in Spain, and the list of them, which are included in the database, has been provided to professionals who aren't experts in pharmacology. So, for example, we've enabled non-experts to have access. So, for example, nursing staff or other professionals, healthcare, that don't have a deep knowledge of pharmacology. So it makes it available to them. It also includes preventive recommendations for each galenical form. It also includes other data of interest, such as blood classification, according to the IARC document. And because it is a web tool, it can be updated periodically. We have a back office which we manage from the Institute, and this enables us to update the information because every day we see new drugs come onto the market, so it gets constantly updated. As we said before, this is just the beginning. This is just the beginning. It just aims to help identify hazards. That's all it is. This is the hazard identification. And then after that, then each establishment needs to carry out its own risk assessment and take its control measures. That's not our job at the National Institute. But we just help with the hazard identification, the initial step. And just to remind you, the aim, the ultimate aim, is to provide information to ensure that workers are protected. This is the control hierarchy, which I have taken from the International Society for Pharmacological Oncology. Now, a first level, top tier, or level 1 drug, if we have that, then you cannot eliminate it because you need it to cure the patient. But At level 1, you can adjust the dose. You can also opt for non-volatile preparations, for example. There is something that you can do. In level 2, we're talking about the robotization to eliminate the source of danger, to take closed system transport, closed transport systems, for example. We can use or work in biological safety booths and sterile environments, for example. We have administrative controls, such as reducing exposure to certain drugs, making sure there are a minimum number of workers in the hazardous environments, etc. And then in some cases, we'd have to use personal protection equipment as well. And really, just to finish, I am finishing now, I promise. Just to finish. What was the feedback that we've got, or what feedback have we received? What are the results or the outcomes that we've achieved so far with regard to the technical document and the database? Well, the technical document has really helped put on the table the fact that some drugs do have hazardous properties and that people didn't know them. They knew that the cytostatic drugs could be hazardous, but they didn't know about other drugs. So that's helped. That's one thing. Since this has all been published through a web tool, this has helped to raise awareness because there's actually a greater degree of access to this database. It can be accessed from any device, from any mobile phone. After the technical document and the web tool were published, we have developed in some regions of Spain different guidelines, best practice guidelines, based on these documents, the documents published by the Institute. So in some autonomous communities in Spain, they have developed their own best practice guidelines for the handling of hazardous drugs in hospitals. And this is very positive, and we are delighted to see that this is actually happening. And also social stakeholders, workers' representatives, unions, etc. They're all collaborating in this awareness raising campaign. They're working with the Institute, and in fact, in some cases, they have come up with their own best practice guides. This is the case of certain trade unions. So there's now a lot of knowledge in Spain at the moment. And then another positive change that we've seen is that we know that health facilities, as a result of the publication of the technical document and the database, are now reassessing the risks in order to adapt their control measures. So this is what we know, that there are different health centres, health facilities in Spain who are now carrying out a new risk assessment in order to adopt the pertinent control measures. So thank you very much for your attention. Thank you very much.
Thank you. I would like to again start with a question from me to the audience and move to the Slido, asking again about your policies in your country, and then I'll allow 2 or 3 questions. So we'd like to ask whether your country foresees any specific regulations or guidance for handling hazardous drugs in the hospital environment. Can you show us the results? I think people have voted. So there's still 1/3, I think, about 1/3, 30% that do not have. So it could be an inspiring example. Shall we go to the next? And then what we heard also is that this tool was first started with cytotoxic drugs, but then it was enlarged to other drugs. So I'd like to know also from the audience whether you have also some guidance that tackle other drugs than cytotoxic drugs. Can we see the answers? So yes, there are some. Not everywhere, but there are some. Do we have any questions via Slido? Can we have those? think I'll have to get up to read that.
Sí, es que...
EU equivalent to the list of NIOSH drugs? Now, have you come across any? You mentioned the Parliament report.
No tenemos conocimiento. No tenemos...
We don't think so, not as far as we know.
Very useful
lista...
guide.
The list is the list published by NIOSH, and that's the one that we've used. We don't know of any other list that's been published in any other European country.
Down there. So could we have a microphone? For the translation, we need to use a microphone, please.
We're sorry if she's using a microphone. We certainly aren't hearing what she is saying up here in the booth, so we are unable to interpret. We do apologize.
Can we have the microphone on, please? Yeah.
Bueno, repito, sí, me llamo...
We can hear her now. Yes, I come from the nursing trade union here in Spain. And in fact, what you've been talking about is a source of concern. According to data, more than 12 million people are exposed to this type of hazard in Europe, of which almost half are nursing staff. Now, I'm sorry to say this after everything that you said, but I'm going to just throw a cup of cold water on you. The cytostatic drugs today, and depending on their handling, because often we don't have the safe closed transport systems that are used. They are just using just normal systems. And when we have accidental breakages of the vials, for example, are not being controlled, which means that we have more exposure as well. And then in number 2, which are carcinogenic drugs, nothing is in fact being done about this at all. Not just in hospitals, but psychiatric hospitals, prisons, at homes as well. In all of these places, we are exposed to these drugs without any kind of prevention. All these different types of drugs, there are many different types of them. We are preparing them as the nursing staff, and we're doing it without any kind of protection at all, completely without any kind of protection. So I ask for a law to be enacted that will protect us, because it's ridiculous and it's unacceptable. I'm sorry,
Did you have a question?
Again, she's not using the microphone, but she's repeating that she is calling for a law that will regulate this. But again, I'm sorry, I don't know if she's using the microphone, but the sound, unfortunately, is not reaching the booth.
Another translation.
Disculpa, ¿el qué puedo...?
Okay.
¿Puedo responder?
Can I answer? Yes, well, the legislative framework, we have the Prevention Act, we have the Royal Spanish Decree, which transposes the European Directive for chemicals, etc. All of this, we have the legal framework, but the effort has to be made by hospital centres and health centres to carry out a proper risk assessment. And this is what is not being done at the moment. What can the Institute do? Well, it can disseminate this information. It can help raise awareness. And this is exactly what we're trying to do, using and publishing these types of instruments so that we can help the situation, try to mitigate the situation. But the legal framework is in place. It does exist. We have different acts. We have the Royal Decree and we have the Carcinogenic Substance Directive. And this is what we have. It's there. And in fact, as from a trade union, you have to make sure that the law is in fact enforced.
There's a very good guide from the European Commission related to the healthcare sector that has already existed for quite some years, is available in all official languages, and that does address cytotoxic drugs. So there's not a list of cytotoxic drugs, but there is a guidance document there for handling cytotoxic drugs. Can we have one more slide or question, and then we need to move on? me read that out. Okay, maybe can you answer that question? Is it possible for you to answer? So why did you, what was the reasoning for including other drugs than cytotoxic drugs into the list, if I understand that question correctly?
Nosotros lo que decidimos es incluirlas en las listas.
Well, we have decided to include on the list the drugs that NIOSH considered hazardous. Now, there are a series of adverse effects that are not included there, like acute effects, for example, which is why, as I said before, what we do is we're just saying what NIOSH considers to be hazardous. We can talk about irritation, nausea, etc. These different efforts, but in fact, this is what the hospital centres, the health centres have to do. They have to detail it. We have just provided a list of drugs with long-term chronic effects, but in fact, what is not included are the acute effects. And this is each establishment has to make an effort to include them and to identify them.
Because there were some answers from the audience that some countries have something on cytotoxic drugs but not on others. Do you consider your database is transferable to other countries? What would be needed to implement it in other countries?
En la parte de la lista de medicamentos peligrosos.
Well, yes, it's true. The list could be transferable to other countries. In the database, where we talk about the drugs that are marketed in Spain, well, that needs to be adapted to the context in each particular country.
And we'll continue discussing at the end. So I'd like to move to the next speaker because I'm wary of time and I'm a bit afraid that we will run over time. And our next speaker is Darren Alkins from the Health and Safety Authority in Ireland. Darren joined the Health and Safety Authority in 2008 and has managed the Occupational Hygiene Unit within the Chemicals and Prevention Division from 2008 onwards. And the unit is responsible for both REACH and OSHA chemicals enforcement, including asbestos and biological agents. Darren is an active member in the EU Senior Labour Inspectorate Committee, Chemicals Working Group, the so-called ChemEx Group. And in this function, he will give a presentation today on the recently developed guidance from the Senior Labour Inspectors Committee, which was developed for the national labour inspectorates and which is addressing health risks from welding fume.
Brilliant.
You have the floor, Darren.
Thank you, Elke, and good afternoon, everybody. And I'll try and be flexible with my presentation because I know others would like to contribute as well. So thanks to Elke for the invitation and to the agency. And I'm delighted to be here representing my colleagues on the ChemEx Working Group of the Senior Labour Inspectors Committee, in particular my colleagues past and present of the subgroup, the long latency subgroup. So just to, I suppose, give you a bit of background, the Senior Labour Inspectors Committee basically assists the European Commission in terms of enforcement of OSHA legislation across the board. And it was informally came about in the 1980s, and then it was formally, I suppose, given recognition or given status in 1995 by an EU directive. The principal activities of the Senior Labour Inspectors Committee, SLIC, is really to define common principles of labour inspection. It's to promote knowledge transfer and an exchange of information between member state inspection bodies. And it also administers an inspector exchange programme, so it allows inspectors to travel between different member states and learn from each other. Under the Senior Labour Inspectors Committee, there's a number of working groups. I'm on the ChemEx Working Group, which was set up in around 2008, and that was primarily set up to interpret the REACH legislation and how it interfaces with OSHA chemicals legislation. But over time, it expanded and evolved, and it takes in other chemicals matters. In around 2014, the SLIC plenary themselves decided, look, we need to focus more on health, or at least redress the balance between safety and health. And from that, Chemics developed a subgroup called the long latency subgroup, which I got involved with and was chaired by Dr. Chris Snaith. And we looked at, I suppose, a range of topics that we prioritise. And the first one that we decided to look at in terms of developing guidance for national labour inspectors was on silica, or respirable crystalline silica. And the second topic which I want to speak to you today about is welding fume. Just to say, Chemics is under the chairmanship of Karen Clayton from the HSE UK, and Dr. Chris Snaith from the HSE UK chaired the subgroup. But I think I'd like to also acknowledge a number of UK representatives that came onto the subgroup, particularly Gordon Smith, who was a welding expert, and also Margaret Wade, who provided a lot of input into the guidance documents. Other members of the long latency group are from the countries, from myself, from Ireland. We've a Dutch representative, an inspector from Belgium, inspector from Sweden, Estonia and Italy. So the subgroup is quite small. We tend to meet about 3 times a year, but we do most of our work through email correspondence and web-based meetings in terms of trying to develop guidance. Our first, I suppose, real success was the publication of our silica guidance, respirable crystalline silica guidance, and that was formally published in October 2016 and launched in The Hague under the Dutch presidency. And that photo on the right there is Karen Clayton, who's on the left in the photo and is chairing the Chemics group. So that's a little bit of background on SLIC and Chemics and where we are at the moment. Just to say, the welding guidance itself we published in November 2018, and I assume you'll all have copies of these slides afterwards, and there's a hyperlink in the first bullet point there which will take you to the online English version of the welding guidance, and that's available for download. And we developed the guidance similar in structure to the respirable crystalline silica guidance. So we've 2 parts and some appendices. So in the first part, we covered background to welding fume, the health effects, the different types of welding, the legal framework, exposure assessment and controls, health surveillance. And we also include a number of additional information sources. So you may have seen in your Good Practice Awards booklet a British Occupational Hygiene Society welding tool, selector tool, and the link is in this guidance for inspectors to access that, including a range of other video links and information sources, including the EU-OSHA website as well. Part 2 I'll cover later on is welding fume task sheets, and this is really kind of where we try and provide good practical information to inspectors, and also an inspection decision tool in Appendix 1, and I'll quickly show you that at the end, and a short example as well to explain how that works. So why did we choose welding fume? Well, as Elke mentioned yesterday, earlier, you know, we could have focused in on industrial chemicals, like for example isocyanates, but we looked at the process-generated substances like silica and welding, and we believe that we need to focus more on that because REACH and other mechanisms kind of deal with the industrial substances better. But also there's a pan-European issue, as with silica. So we've over 2 million welders, but we've also quite significant amount of what we call part-time welders in maintenance and construction. So we've quite a large population of welders, be it them full-time or part-time. There's high potential for exposure to hazardous substances. It's a real cocktail mixture. It's a cocktail between gases and particulates. It can be quite complex in nature, and that's to do with the various metals involved. For example, you have cobalt there, chromium-6, manganese. There's also other hazards around the generation of UV radiation because of the high temperatures of welding. That can generate ozone. It can generate nitric oxide, nitrogen dioxide, and also, depending on the metals that you're working on, you can develop carbon monoxide and carbon dioxide as well. Exposures also can be complicated by the surface contamination of metals that are being worked on as well. For example, you know, degreasing agents like chlorinated solvents, when they're heated up, you know, you can have generation of chlorine gas or phosgene. And there's also, not just to focus specifically on the chemicals, we provide information to the labour inspectors about a range of general hazards, because if they're going into a workplace, they need to be aware of the associated hazards with welding, like electric shock, confined space work, noise, arc eye, which is inflammation of the cornea once you're exposed to UV radiation. It can be very painful, and other injuries. So I think we have a good business case to focus on welding fume, and it's quite a significant potential for exposure there. In terms of the health effects from exposure to welding fume, it's primarily the respiratory system. We've both acute and chronic effects. So in terms of acute, we have upper respiratory tract irritancy, temporary lung function reduction, metal fume fever, which is very like pneumonia. We also have acute pneumonia as well, potentially, and there is advice out there that welders should be vaccinated with pneumococcal vaccination. Again, there is difficulties there knowing the true link, but there seems to be an issue with that. Also, generation of carbon monoxide can have carbon monoxide poisoning effects, and potentially asphyxiation as well. So if you're in a confined space, the shielding gases that are used in welding can deplete the oxygen levels and lead to asphyxiation. So they would be the acute type of effects. In terms of the chronic effects, you have chronic obstructive pulmonary disease. And again, the photo up in the right-hand corner is a video. If you click on that photo, it takes you to a video of a Dutch welder who developed COPD. He's now 40 years of age. He's on oxygen, he's in a wheelchair, and that's all as a result of exposure to welding fume. Welder's lung is, again, it's a benign sort of disease. It's more metal deposits in the lung causing fibrosis. But occupational asthma would be a key long-term health effect as well. And again, the photo on the bottom right-hand corner is from the UK. It's a video that they have there, an interview with Phil the welder, who developed occupational asthma and the effects that it had on his life and his family. And why we're here, this workshop is about, obviously, carcinogens. And as you may or may not know, IARC has classified welding as a group 1 carcinogen, and again, there's a number of substances in there which give those effects. Other health effects, neurological effects from exposure to the manganese, oxytoxic effects. This is where you can have accelerated hearing loss with a combination of noise and manganese, reprotoxic effects, depression, skin effects coming into the consumables, the rods and that are purchased for the welding itself, especially rods that would contain nickel and chromium. So again, a wide range of health effects. We also, in the guidance, explain as simply as we can the different welding types. I'm not an expert in welding, and it certainly is a complicated process, but we've covered the common ones. So we cover metal and air gas MIG, TIG, and flux cored arc welding and shielded metal arc welding. But we also include other techniques such as plasma cutting, laser cutting, and flame cutting that can give off similar levels of fume. And we explain how the different types of welding generate different levels of fume. For example, tungsten in air gas or TIG welding is quite low in terms of fume generation, whereas metal in air gas is quite high, and that comes into the hierarchy of control later, as you'll see, in terms of trying to advocate substitution of different types of welding. The legal framework is explained. The framework directive is obviously underpins the risk assessment, but we specifically focus in on the chemical agents directive for substances such as nickel and manganese, and also the carcinogens and mutagens directive. And as you may know, chromium-6 now is in as a binding occupational exposure limit value, but there is a derogation there for welding for, I think it's up until January 2025. We also explain the occupational exposure limit values, but really, we don't expect labour inspectors to be carrying out any monitoring, especially the general national labour inspectors. But again, we explain that's an important part of the risk assessment too, and the majority of the chemicals either have an indicative occupational exposure limit value or a binding occupational exposure limit value, including the gases. But the key thing for us in terms of advocating an approach to a labour inspector is to use the hierarchy of control, which was mentioned earlier, which is on your right there. And what we've tried to do is develop that into tables, useful guidance for labour inspectors. So I won't go down through all of this, but we start with elimination, and we suggest things like, can they cold cut using guillotines? Do they have to weld? Moving to substitution, so you may move from MIG, metal inert gas welding, to TIG to reduce the level of fume, to use cleaner rods and wires. Even as far as automation, can robotic welding be used? So it's really prompting the inspector to think, has the employer or the duty holder kind of considered, are they looking at this, or are they going straight into what they've always done? We then talk about ventilation. We start with on-gun ventilation, which is very effective but requires a high level of training to be effective, to benches with extraction slots to the back of those, to flexible and hinge arms. But we also explain that just because something's in place doesn't necessarily mean it's working, and what checks and balances need to be done. Moving down the hierarchy of control, can the area be segregated? Have the area been segregated to keep other workers who are not welders away from the area? And then RPE, of course, as you know, is the last in terms of the hierarchy of control. And really what we're trying to get is inspectors to walk in and if they see no ventilation but the use of RPE, we wouldn't consider that good practice, even if the RPE is suitable for the task. So we've expanded on the hierarchy of control and tried to provide very practical guidance. And then that leads us into providing actual specific task sheets for the different types of welding. But before we get into the task sheets in part 2 of the guidance, we talk about inspector safety, because that's critical. Because my own inspectors, we have a dynamic risk assessment approach, that when we walk into a workplace and if we see somebody over in the workshop and they're generating fume, we don't automatically go over and start making our inquiries. We stop the works remotely, pull the worker away, and deal with the duty holder then. So it's trying to get that point across, that inspectors can be exposed as well, and particularly to arc-eye. And again, part of this was looking at what type of PPE would be helpful as well for inspectors, and that's something SLIC is looking at across the board. Each task sheet is divided into 6 sections, so we explain what the welding process is about, what the recommended controls are, but then we get to possible actions. So if we have a red, orange and green sort of traffic light system, and if certain controls are missing, we're advocating to the inspector that if it falls into high category, they may issue a prohibition notice, stop the works, or if it's in a medium high risk, they may take other action. So we've tried to provide that with a big disclaimer and caveat in all our guidance documents, that each member state labour inspection service has their own discretion and their own approach if they want to diverge away from the guidance that's given. Just moving on to the inspection decision tool. So this was something that was developed by Gordon Smith, the inspector from the HSE UK, and it's basically, it's not an exposure assessment that the labour inspector will do, but they can use this tool, a semi-quantitative tool, to give an indication level of enforcement they'll be required to give. There's 4 key factors, one being fume composition, B being fume concentration, then the exposure time and the location or where the work is being carried out. There's ratings for each of these. These are added together to give a total number, and then they're multiplied by whatever control factors are in place. So if the total number is less than 7, there's no cause for concern. If it's in medium to 18 to 20, there'll be certain action required, and if it's greater than 20, well then you're into prohibition notice or possibly referring to a specialist inspector. So just to give you an example of that, just on the right hand side I've just shown the table from the appendix with the two top factors. But for example, if an inspector was to walk in and see this taking place in a workshop, this scenario, this is a worker doing metal inert gas welding on mild steel, and we'll take into account that it's clean, the steel. They will make an assessment from the table. In this case, it would be 1 in terms of the fume composition. The fume concentration is a visual assessment. So we're not talking occupational hygiene monitoring here to make a call. It's basically, do you see a plume? Is the plume being ventilated, or is it around the worker's head? Is it dispersing? In this case, you can see there's a visible fume and it's not dispersing. The next factor is the exposure time. So does the worker work full-time welding? And normally we give a 10 to 25% of the working day for a full-time welder and less for those who are part-time welding. In this case, this is a full-time welder, so you give a rating of 2. The location of the workshop, in this case it was a small workshop, and the rating is 2. So when you add those together, you get 7. And in this case, the control factors is, was there LEV or no LEV? And in this case, no local exhaust ventilation. And that's given a 3. So you multiply 3 by the 7, you get 21. That's effectively a high risk. And the advice in the guidance is that to stop work and to take control. So it's high level. It certainly doesn't involve any occupational hygiene monitoring. But again, a lot of labour inspectors out there are not specialists, and we're trying to develop tools or practical tools which are easy to use, even without that specialist knowledge. And again, we've taken this on board in Ireland, where we've modified it slightly. We've developed operational protocols around it. And we're also, the guidance itself, we're liaising with the Irish Steel Fabrication Association, who've taken an interest because this guidance is available publicly, and they want to develop it, do a project as well and get our input into it. So I think it's been, this type of guidance, this type of approach has been very helpful for our labour inspectors. So for my final thoughts, just to wrap up, that the ChemX remit is there to support the Senior Labour Inspectors Committee in promoting application of secondary law. And they'll continue to meet 3 times a year in Luxembourg. The guidance produced by ChemX is for non-specialist national labour inspectors, but it is publicly made available, and so that employers can understand what inspectors expect at the workplace. And we will be, and we have evaluated the published guidance. For example, we have issued out questionnaires to all member states only recently in terms of how the silica guidance is being implemented and used, and we expect responses back by the end of November. So it'll be interesting to see how it's been taken on board, and we'll do something similar for this welding guidance. And we're currently working on some new guidance based around the hierarchy of control. So thanks very much for your time.
Thank you, Darren, especially for catching up on time. You mentioned that the guidance is available in English.
Yes.
So will it be translated?
Yes, it's basically going to be forwarded on to translation services. We'd expect probably mid-2020. A part of what we do, as well as getting the English translated into the other member state languages, we also get technical experts in each of the member states to have a look at it, just to make sure the technical aspects are correct. So that takes a little bit longer, but we'd hope by mid-2020 it'll be available up on Circa BC, where we currently have the respirable crystalline silica translations made available.
Okay. So I think we'll take 2 questions, but before we do that, again, I'd like to ask the audience a question. And could we switch to Slido again? To get some feedback on you, on the guides from ChemX. So do you think the practical guidance and tools developed by ChemX for national labour inspectors will improve interventions on carcinogens in the workplace? And we're getting into the discussion here already.
Okay, that's good. Thank you.
So, you got some good feedback.
I'm happy with that.
Darren. Yeah. Can we maybe have other questions on Slido? So let's have some. Do you have any questions from the audience? Do we have any questions from the audience for Darren, or? Yeah. Okay. Nice one. So I'll try to read it out.
Yeah, I think there's a difficulty. Is the rate of illness from welding high, workers, and does the quality of steel have an impact? Well, absolutely. I think there's a difficulty with having true figures or illness figures for welding. I mean, we see cases in Ireland, with welders sporadically. It's not, a lot of these illnesses aren't reportable in member states, and I think that's a difficulty always with data. And because there's confounding factors as well. For example, COPD, the primary cause of that is through smoking, or it can be exacerbated by smoking. So again, it's very difficult to know the rate of illness in welders, but certainly there's plenty of evidence there to show the direct causation between the chemicals and the illnesses themselves. In relation to the quality of steel, absolutely. As I mentioned earlier, if you have surface contamination on the steel or a mix of alloys, yes, you can generate a lot more, a more complicated mixture, I suppose, is the best way to describe it, with different contaminants. So, as I mentioned earlier, if there's still chlorinated solvents left on steel and there's high temperature applied through the welding, it can give off phosgene, it can give off chlorine gas, as well as whatever's in the rod in the consumable, and also on the steel itself. So it does, absolutely, there's a difference in terms of the quality of the steel.
Can we have more? Is there any more question from the audience? And we'll take one more.
So, for other kinds of health risks in terms of chemicals, yeah, I think the next, for us in chemics, we're developing a more general guidance document for labour inspectors who basically have very baseline knowledge of chemicals. So it'll be based on the hierarchy of control, and it's looking at simple things like, well, not simple things, but safety data sheets. But what is a safety data sheet? What are the different pictograms? What are different types of chemicals, good and bad practices that you'd expect to see? Because really, it's going to be, I suppose, the best way of providing information out to labour inspectors, we feel now, is like through train-the-trainer material, where you'll have somebody with more specialist knowledge in a labour inspectorate using guidance that we provide. And we're hoping that we will get plenty of visual representations of what good practice is and what's bad practice. So if you walk into a bakery, if a labour inspector walks into a bakery and they can see, flour levels are quite high, there's RP being used but no ventilation, we automatically want them to assume or to take the position that that's poor practice and to take some action. But in terms of understanding, going beyond that, whether the RP is correct, what type of ventilation is needed, what the flow rate should be, there'll be a requirement to refer on. So the answer to this question is, we are looking at more general, kind of across the board, at different health risks, but we're not going to do one topic at the moment. We're going to kind of a more general approach, and then we may look at isocyanates then at a later date. So that's currently where we're at.
Thank you, Darren.
Okay.
I think we'll move now. I'd like to ask you to stay here, and I'd like to ask the three representatives of the Working Party Chemicals to join me on the stage. And we have, and I'll move. Could we have the general questions, maybe? Yeah. So now I realize that I'm running a little bit over time. We started a little bit late, so I hope you'll forgive me. To start the discussion, I would like to present the three additional persons who joined us here on the podium. This is Sirku Saarikoski, who's from the Ministry of Social Affairs and Health in Finland. He's a ministerial advisor in the legislation unit of the Department for Work and Gender Equality in the ministry, where she's worked since 2012, and prior to joining the ministry, she's worked as a cancer researcher in the Finnish Institute of Occupational Health. Sirku is an alternate member of the Advisory Committee on Safety and Health at Work, and a member of the Working Party Chemicals of the Advisory Committee. We also have Martin Wieske, who is from the German Non-Ferrous Metals Association, representing here the employer side, and who's responsible there for all issues related to occupational health and safety, but also classification and labeling and hazardous substance management. And this, since 2004, is also a member of the Working Party on Chemicals. And we have with us Tony Musso, who is from the European Trade Union Institute, a senior researcher, has previously worked in industry and then joined the ETUI in 2003, takes part in various REACH-related EU working groups, and is also a member of the Working Party Chemicals in the Advisory Committee on Health and Safety at Work. So I'd like to ask you in 5 minutes to react on the presentations and on some of the reactions of the audience today. So maybe Sirku, you could start?
Okay, thank you. First, I would like to thank for all the presentations, and I think these really nicely illustrate how it is possible to really create practical solutions and practical tools which can really be used at the workplace, not just something theoretical, but really practical tools which can also be spread to between the countries and so forth. So I think this is exactly what we need. But then to my own part, so we agreed with Elke that, so as Elke mentioned, I come from the legislation unit, and so I don't work with good practices, but we agreed that I could mention some of the legislative initiatives we are working with and which are relevant for these, regarding these presentations. And so what we are doing actually in Finland at the moment is that we need to transpose the amendments of the CMD. So we need to transpose the limit values, and at the same time we are doing some additional national extensions. And some of those, so what we have, we are going to add to our Annex 1, so under the scope of our carcinogens legislation, the welding of stainless steel. So we are going to so we know that IARC has defined all of the welding carcinogenic, but at this moment we are going to restrict it as stainless steel because there is most evidence from welding of stainless steel. And actually already these, the welders should have been considered as under being exposed to carcinogens because there are many carcinogens in the welding fumes. But anyway, this makes it more clear for the employers. And the other thing we are doing is that we are also planning to include under the legislation and again under the Annex 1, which is similar to if it would be under the Annex 1 in the CMD. So all of the requirements of the CMD would apply, would be to add work involving exposure to antineoplastic drugs. And the way we have approached this is that we have been connecting this requirement for the ATC classification. So it's anatomical therapeutic classification of the WHO. So the drugs which have been listed and which based on this classification can be considered carcinogenic will from this on be in the scope of our carcinogens legislation. And there are most of the carcinogens can be considered, cytostatic drug can be considered carcinogenic because of their mechanism of action, and there are only a couple of groups in the ATC list which can be considered non-carcinogenic, like monoclonal antibodies and protein kinases. But just trying to squeeze it to short time, so I guess I had to stop here.
Can I ask you, Martin?
Yeah, thank you, everybody. Thanks for the presentations. I think all examples were quite showing us quite detailed work, and that is my experience, or let's say my perception. It's detailed work on some issues which are reflecting long-lasting problems. So I learned that, for example, when we look to the cytotoxic drugs, that we have quite some long-lasting experience with that. We have the same with some of the disinfectants ingredients, and of course with welding. So all are quite long-lasting challenges, and we have learned a lot of new aspects, and I think that is something which is encouraging, that even if we have problems for a long time, we are getting better and better, but we do not find the full solution. So we need to get better on that. But what we also learned, and that is also, I think, important for our future communication on carcinogens, for example, that look at the disinfectants or look to the cytotoxic drugs, they have issues which are two-sided, two faces. Of course, we use them to protect people, but on the other hand, they are harming people. So we need to balance these two aspects. Of course, everybody would like to have the possibility to be treated by cytotoxic drugs if you're suffering in certain aspects. But on the other hand, of course, the nurses need to be protected. It cannot be that we put people on risk which are trying to help others. So, of course, we need to focus on these kind of aspects, and classification, I think, is one driver of that. But classification is not everything. And what we also learned is when I look to the database in the Vienna example, that it leaves room of maneuver for the people addressing it. So I think it is very important that you more or less never has a black and white solution. So if you, for example, go from one to the other and try to substitute for one effect, then of course you have to take into account the drawbacks. One drawback which was mentioned is, I think that is quite important, is bacterial resistance. What we never would like to have is increasing resistance in hospitals by buying in, let's say, better performance. So I think it's all about balancing. And that means that it's all about risk communication. And that was why I was voting during one of the Slidos for getting more information across and making everybody clear what is really at stake. Where are the benefits, where are the drawbacks, and where are the risks? I think that is important to discuss, because it's not all about hazard, it's hazard times exposure, because that is really the risk which matters at your workplaces. So of course, if we have carcinogenic substances, we need to be aware of them. But if you, for example, go for OSH for welding, and OSH is the best area to address that, because it's something which occurs at workplace, which are coming at workplaces during your procedures. So that we have a lot of information by all the ingredients, I think we do have. We recognize that for most of the ingredients we have OELs. And that is the last impression I have, and that is something I would bring across, also as a learning lesson for me, that in different member states you go for different solutions. We heard that there is a kind of huge warning system in the UK or in Finland to say, okay, certain areas of welding are a problem. In Germany, I can tell you that we are going for the OEL approach for all the different welding techniques. We know all these techniques. We know that it's not always depending on the steel. There was one question on that. It's also depending on the brazing stick material, much more often depending on that one. So, you know, to have an overview on the technique and then to define your problems and find really an accurate answer on that. So in Germany, we have a specific technical rule on the way for welding. We have quite well-established guidances on cytotoxic drugs. And of course, the same is when it comes to the disinfectants. I think that is something we have to keep in mind. We need to find gross solutions for all us across Europe, but to implement that in a way that it is efficient in all the member states. I think that's where I should stop now. Thank you.
Thank you, Elke, for having me. Of course, I welcome the three initiatives that were presented, and they are all three very good and very useful, I guess, to reduce the risks at the workplace. Maybe a comment on across the examples that we've seen. It seems to me that one of the problems that we have is that the workers have not enough information. They don't know what they are exposed to. And that's a big problem, of course. For the disinfectants, I think that we have a loophole in the biocide product regulation, is that workers' exposure, so the workers that will use those products are not taken into account in the risk assessment of the active substances. So that's one of the big problems that we have, and that we might want to improve in the future. For the cytostatic drugs, that's the same. You were explaining that nurses, they are working on a table, so they are really exposed, and they don't know to what they are exposed. And I'm not totally agree with the speaker on cytostatic drug, because you mentioned that one of the problems is that there is no labeling. So there's no harmonized labeling for those substances. So, of course, workers, they don't know the hazards. And again, maybe here one of the solutions would be to try to improve the legislation, and I totally agree with you. And one of the possibilities would be to include cytostatic drugs in one of the annex of the CMD, the Annex 1, so that in that case, the hierarchy of control would apply to those substances. So it means, of course, we don't want to substitute them because they are useful, but at least we go to the closed system and to the reduction of exposure. So that would be a mean of improving the management of these hazardous drugs. And you said we have millions of workers exposed to those chemicals. What struck me also is that, be it for the disinfectants or for the cytostatic drugs, we have heard a lot of them are reprotox substances or might have reproductive adverse effects. And so maybe here one of the solutions might also be to improve the current legislation. And as you know, the CMD applies to carcinogens and mutagens, but not to reprotox. And that's really something that we need to fix. And so certainly what we need to do in the future is to extend the scope of the CMD to reprotox substances, so that again, we will have the same hierarchy of control measures. So elimination, substitution when it's feasible, and if not, closed system and reduction of exposure. So these are quickly my main comments.
Can I ask whether there are any reactions from the speakers to the statements now? Whether you have any immediate reactions? No? If not, yeah. Are there any? So then, would you like to say something?
Yeah, because of the resistance of bacteria, you said, yes, that's true. And of course, we need also in future a broader range of active substances to avoid resistance. But we found out, for instance, that the oxygen releases, they have a broad spectrum of activity, and there is not many hints that bacteria resistance is growing. So, for instance, yeah, I think there are some biocides that don't develop, or where bacteria don't develop resistance so easily. Yeah, just one thing.
Very good. I think we'll take 2 Slido questions, and then I have a final question for you that I'm going to report on tomorrow because we already run over time. There's no questions. Yes, is there anyone who would like to react directly? We have a microphone in the room. Yeah.
Well, thank you for the presentation. I think it was very interesting. I missed, actually, as an occupational hygienist, in any of the presentations something. And one of the things was discussed, the workers don't know what they are working with. That's one point. Secondly, there was that question, you have to inform everyone at the workplace. So in many cases, for example, what I missed is, well, if you go to the disinfectants, for example, it was clearly stated that one of the things missing was the link with, there are European standards on contact time, oxygen releasers. Well, if you are exposed to high amounts of oxygen, it means that you are not using it right, because normally the oxygen is reacting. So half-life in air, for example, although I think, the main issue is if you use all those tools, and that's a hazard assessment, pure hazard assessment, that's the first step as an occupational hygienist, what you do. Very interesting, you have a database. But on the other hand, what is missing here is if you only tell this to the worker, they think, oh, I look to the list, my job's finished. That's my risk assessment. And that is what you see in many cases at the workplace. You have many tools developed, you have many guidances, and everyone thinks, well, I have followed that, it's the end. But it's not. In many cases, it is the beginning. And, that is, if I'm just, from practice, I see in many cases that they stop because there is some guidance. For example, I'm a fan of the OIRAs. Very interesting, but for me, as an occupational hygienist, it's the beginning. It's the first step, and you have to continue. And in many cases, what's happening is, well, I have done that, I have done my work according to legislation, and then it stops. And that is very dangerous in my point of view. And because, for example, in the disinfectants, I do know, I did a lot of work on the European standards on contact time, how much contact time you need for sufficient disinfecting properties and the efficiency of disinfectants. You should include this because you don't want someone to just choose on hazard properties. It's very dangerous in my point of view as an occupational hygienist as well. Because, for example, I just take the example on disinfectants used for Legionella. It's a very good example. If you only look at the hazard statements, you can make huge mistakes. So you have to take this into account. And this is for all of it. I do know the inspector guidance, very good on welding fumes. And you mentioned that it is made for people who don't have a lot of experience, but the problem is that those are all freely available. You know how it goes. And everyone is following that and make this sum and comes at 21. And very bad. And then everyone thinks, well, my job's done. So there should be a disclaimer, like you said, and any of those tools, this is not done when you follow this.
I think it was said. It was said for the cytostatics database, and I think, yeah, okay. But I think we should give the speaker now the opportunity to answer to that.
Yeah, thank you very much. The exposure time is considered in the database. So if you just try to compare products, you have to fill in the spectrum of activity and the exposure time, and you only compare products with the same exposure time, for instance. So we try to consider it.
Okay. Would anyone else like to react from the speakers first?
Well, just talking about the tool, as I said in my presentation, our tool, the tool very clearly states that it is there to help with the first initial hazard identification. And we say that very, very clearly. It's not the end point of the process. At no point do we say that it's a document for carrying out a risk assessment, etc. We say very clearly in the instrument that we have developed that it's a starting point only.
Darren, would you like to say something?
Yeah, no, thank you very much for those comments, and it's really on the welding, and yeah, absolutely, there's disclaimers in there. It's only a starting point. The difficulty is a lot of these smaller SMEs just don't have access to occupational hygienists, so you have to get a baseline. And again, a lot of our labour inspectors don't have the knowledge you have, and that. So we have to get an intervention at a baseline, and then hopefully you can recognise where you may need to refer out to a specialist and bring somebody in. So it's a stepwise approach, but hopefully we'll have a wider impact. But absolutely there's difficulties with access to the competence that you need sometimes around these complex issues.
Does anyone else want to react from the
Sí,
podium?
yo por alusiones.
Yes, I'd like to react. Now, nursing staff understand pharmacology and we know what we're handling, but sometimes we actually think more about looking after other people than looking after ourselves. If we don't have personal protection equipment, which are recommended in the guides, etc., when they're not available, this equipment, this protection equipment isn't available. What happens when these biological booths in which these drugs should be, I'm talking about group 2 here, by the way, when we don't have these booths in a hospital, because they would need a huge investment in material to get these booths and the transfer systems and in staff. And we simply don't have these resources now today in Spain. Staff, nursing staff, staff that works in pharmacies, in prisons, etc. They don't have the information about what's in their hands and with what they're using and working with every single day. For example, there's one drug that we handle more than once a day, in the morning shift and the afternoon shift, every single day. The mycophenolate, for example, is one example of this. So recommendations are all well and good, but I think the time for recommendations is over, and now it's time for legal action. If we want to audit, if we want to say, you're doing this right, you're doing this well, to demand risk assessment about type 2 and type 3 drugs, which pose a reproductive risk, for example, there has to be something concrete that will protect us and which will oblige professionals and hospitals to use the resources they have and to purchase those resources that they don't have. Because we're not just talking about the nursing staff of the 1970s. We're talking about today's people, and we have to evolve. And this is not just a question of money. It's a question of making people responsible.
One last statement, and then we'll go to a final poll, because we have already run over 20 minutes. Then we'll go to a final poll that I will report on tomorrow.
Solo queríamos pedirle a...
We would like to ask the Ms. Sarikoski. They're saying that they're transposing the directive in Finland, and they're changing some of the directives or changing some aspects, changing and not changing other aspects. Could you just talk a little bit more about this transposition that you're doing of the directive into Finnish legislation, please?
So in general, we're transposing the directive as such, but then we are doing some additions, and one of these additions was the inclusion of exposure to antineoplastic drugs under the annex, which defines that the carcinogens legislation will also apply to these antineoplastic drugs. So it would be comparable to, like, if in the carcinogens and mutagens directive, the antineoplastic drugs would be added to the Annex 1 of the directive. So the requirements will apply. We already actually have had previously quite many or a few of the antinaplastic drugs under this legislation already, but just individual drugs. And there are hundreds we know that we already have a national registry for employees who get exposed to carcinogens. And we already in this register, we have hundreds of nurses who get exposed to these individual drugs. But now we just expanded it to all of those drugs which meet the classification under this WHO ATC classification.
Very good. So I think I will stop here, and I have a final poll for you to vote on, the final Slido questions that we first showed by mistake, which I will report on tomorrow. While we put on the questions, I would like to say thank you to everyone, to the speakers, to the translators. You have the opportunity of continuing the discussion, so I see that we've stimulated discussion with the organization of this session. You have the opportunity also to speak to the speakers this evening and to continue the discussions. I will report tomorrow on the session, on the presentations, but also on the statements from the audience tomorrow morning. So could we have the Slido question? The last poll. Oops. Yeah. So you have the opportunity to vote on this one. And I can see that actually what was discussed here, awareness raising and training and information, were identified as the most important issues. And that's something, and advice for substitution. So that's, with that conclusion, I will go into the session tomorrow. I wish you a very nice evening. I would like to let you know that the evening program starts at 19:30, so at 7:30. There was some erroneous information that it was 8. No, it's 7:30. So I look forward to seeing you there. Thank you very much.